Hello. In this talk, we are going to look at artifacts that you may encounter in histopathology as well as cytopathology. So let's first define artifact, and this is anything, especially in a histologic specimen, that is caused by the technique used. It's not a natural occurrence and it is incidental. You can also define it as a structure or sometimes a phenomenon, such as cautery artifact, that is not normally present in the living tissue, and the problem is to recognize these and not to confuse them with normal tissue components or pathological changes. In some situations, the presence of an artifact can compromise an accurate diagnosis. This table shows an overview of where certain artifacts can occur, and I particularly want to highlight this specimen-to-specimen contamination. This is a very potentially serious artifact because it can cause wrong diagnosis and wrong treatment. For example, if a contaminant from another patient's specimen, malignant cells, find their way onto a biopsy which otherwise shows benign cells, and this can potentially be misdiagnosed as cancer and lead to serious consequences if not recognized as an artifact. So when we think about artifacts, we can sort of think about the various stages of tissue handling. So for example, heat damage or cautery artifact, this is something that I'm sure many of you are familiar with. This occurs even before we receive the specimen. There can also be certain contaminants that can find their way into the specimens from extraneous objects such as cellulose, gauze, hemostatic products, starch contamination, etc. And here is an example of a type of artifact. This is a salivary gland, and you can see here the serous acini, and this is the area of the artifact. Is this oncocytic change? Actually, this is quite often seen in salivary gland resections where there is clear-cut cautery artifact here. And this is somehow an effect of cautery where the salivary gland acini just start to appear very oncocytic. So it's not true oncocytic change, and take note of this and you can look out for it in your salivary gland resection specimens. Here is another example, again, with this so-called oncocytic looking cells, but it's actually due to cautery. Now this is what you're very used to as well in recognizing cautery artifact. Sometimes this can be helpful because it can tell you that it's probably a margin, but it can also hinder your evaluation of whether there are malignant cells at the margin. Now when it comes to fixation, there can also be lots of artifacts, for example, zonal fixation or uneven fixation. Perhaps the outer rim is fixed but the inner is not. And also formalin pigment, mercury pigment. Tissue processing can also give rise to shrinking, and usually there is about 15% tissue shrinkage after processing. So here is an example of this uneven fixation. In a lymph node, you can see the outer periphery of the tissue is well fixed, but the central region is not so well fixed. So this is why it is important in larger specimens to slice them serially first in a way that they can be readily reconstituted for trimming if they're going to be lying in formalin before trimming, especially those who are going to be trimmed the next day or 2 days later. Now coming down to actual sectioning, microtomy, and section mounting, lots of potential artifacts, and these are some that I'm going to highlight. Knife lines, Venetian blind effect. This is from cutting and you get lots of parallel holes in the specimen. Holes from roughing. Roughing is when the techs are just cutting and flattening the surface to get ready to cut a nice section from the block. And then bubbles. Sneeze artifact is literally when somebody sneezes, so the squames from the oral cavity will actually fall onto the specimen. Fungal contamination and also folds in the specimen. There can also be artifacts during staining. For example, if the de-waxing is incomplete, there can be residual wax on the section, and this can block or hamper the evaluation of the section. So here is actually what wax looks like. This section, you can see the tissue here, but there are these purple blobs, and this is due to incomplete de-waxing with residual wax on the section. This is an example of Venetian blind artifact, and it is when the knife cutting is not even. This is an example showing knife lines. And this one is actually a lymphoma, and this is a thick section. And when you compare this to the thin section, you can see the nuclear chromatin much better. Just again to compare with the thick section. So sometimes the thickness of sections is important, especially in certain types of tissues like lymphoma specimens. This is an example of bubbles where the section itself has got uneven areas and therefore they stain unevenly, as you can see here. There can also be bubbles during the mounting process, and eventually sometimes these bubbles may end up having this kind of very ugly appearance after they dry up. So these cases generally tend to need remounting. Frozen sections can also give rise to artifacts, for example, ice crystal artifact. So it's very important to make sure that your forceps is dry and also the surface on which you are trimming your frozen section specimens is dry so that you don't introduce water into the specimen. And sometimes even for decalcification, for example, if there's over decalcification, this can give rise to a very hazy appearance of the specimen with loss of nuclear detail, and of course it can also impact immunohistochemical staining or molecular tests. So here are some more examples. Now this is actually an extraneous structure or material that is seen on sections, and I think some of you should be able to recognize this. This is one of the hemostatic materials, and it is gel foam. It's got a very classical appearance, so if you've seen it once before, you probably should be able to recognize it again. It's not fibrin, it's not necrosis. This hyaline pinkish material that is acellular is another hemostatic agent, floccyl. So there are several classes of resorbable hemostatic agents. There's gelatin-based materials such as gel foam, cellulose like Surgicel or Oxycel, and there's also microfibrillar collagen, and these are the proprietary names, Evitine. And there are also certain structures which can be left in situ in the patients where they're of course not supposed to be, and then later on they can give rise to tumor-like masses which are inflammatory in nature. So examples would be textiloma, and you can just guess from the name that it's basically fabric left in situ, giving rise to a swelling or tumor-like mass. Gauzoma, muslinoma, and even this term gossipyboma. Gossipyboma actually is a textiloma. It's essentially a retained foreign object, and this term is used for surgical complications resulting from this retained material. If you're wondering why the name is so interesting, it's because the Latin word gossypium means cotton wool or cotton, and boma actually means a place of concealment. So clinically, if the patient had had a tumor and then there is a mass at the site of the previous surgical excision, of course, the differentials would be, is this a recurrence? And sometimes this is actually due to things that have been left behind. So here are examples. This is what gel foam looks like, and I've shown you a picture earlier on microscopically. This is Surgicel, and you can see here this kind of structures that look a little bit like plant cells. Oxycel is quite similar, except that it is hollow. And Evitine is this microfibrillar collagen that actually kind of looks like our own body collagen. Now, I've shown you this picture because I want you to think about what are the correct orders of processing a specimen. So which one comes first, A, B, C, or D? So I want you to think about this. I'm just going to give you a few seconds to think about it, to put it in the correct order. And so here comes the answer. It is actually this first, which is you remove the blocks from the processor. Then B, you embed the tissue into this metal mold. Then A, where you cut the sections using the microtome. And then finally C, where you float the sections in the water bath and then you fish them. It is important to know the order because this helps you to work out cases of specimen to specimen contamination. So this is one such example of a floater. I mean, in this instance, it's actually quite obvious because this, clearly looks like it's just sitting on the surface and there's nothing else here. So this is a clear-cut example of a floater. Probably this tumor is very friable. It's not always so obvious. So if you remember this table, specimen to specimen contamination is an important artifact, and this can occur at various stages of specimen handling or tissue handling. First of all, the grossing or dissection, and this is usually via the forceps, instruments used, or from tissue fragments that have fallen on the dissection board, and then they can be transferred into the next specimen if the board is not washed properly. They can be on the knives or on the forceps or scissors, any instruments that are used. Tissue processing is when it's in the processing machine because our cassettes are, clearly fenestrated, right? They are holes. So very, very small tissue pieces can swim from one cassette into another. And how we minimize this is to wrap up very small or friable tissue fragments in filter paper. Embedding is another very important and rather common station for contamination. This happens when little bits of one specimen get caught in the grooves or the teeth of a forceps, and then it gets transferred into the next specimen. So you can get it from the forceps, from the molds, the metal molds, the hot plates, or cassette covers. And then flotation baths, when the sections are swimming in the flotation bath before fishing, sometimes bits of other sections can also come onto the wrong slide. Even during staining, the cells can be shed from one section or even a cytological smear and deposited on another slide. So this line of distinction is very important because above this line, the contaminant is actually in the tissue block. And below this line, it is only on the slide and not in the block. So one very simple way to determine where or which step the contamination occurred is just to do levels. If it is on the slide alone, clearly it will not appear on subsequent levels. Now, how do we handle floaters? I think the most important step is to first recognize them. How do we recognize them? Well, if the tissue looks different, for example, a fragment of malignant tissue in an otherwise benign specimen, it could be the same tissue type if you have a gastric biopsy. Most of it looks benign, and then suddenly in one area you have one lone malignant small piece. So this is kind of something that should raise some alarm bells. If the fragment has a different ink color from the rest of the biopsy tissue, I mean, this is not from your own inking, but when passing small biopsies, for example, if you see a yellow piece and the rest of the tissue is actually blue, then this also may be a clue that you're dealing with a floater. If there is a small piece that's away from the main section, that is yet another clue. So your radar has to be on for this. So you can look at the block, you can do levels. If they persist, then you know it's in the block. If it disappears, it's either at the flotation bath or the staining stage, and then this just confirms your impression of a floater. You don't have to do any other investigation. If it is in the block, you may want to check the previous specimen that has been trimmed or embedded or sectioned. So this takes quite a bit of effort, whether it is on the same trimming station or embedding station, just to be sure that you really are dealing with a floater. If you can match it to the original donor specimen, that is a good thing to do. And when all else fails, you can actually perform microsatellite testing, and you can see that the tissue pieces are from different patients. Now, the best way is really prevention. So how to prevent or minimize floaters when you are trimming or embedding specimens? You should avoid doing consecutive specimens of the same type because in this instance, it becomes very, very difficult, sometimes even impossible to decide whether it's a floater or not. I know this is not always possible because we do get very high volume of certain types of specimens like GI biopsies. Inspect and wipe the forceps. Make sure the forceps are clean between specimens. And for trimming, you can do the friable or the messy specimens last. Those are likely to shed a lot of material. And wash the trimming table well between specimens at the end, also at the end of trimming. Now, this is a case of a skin abscess, and this patient had diabetes and had a carbuncle or a chronic abscess in the skin. So we can see that there are some macrophages, neutrophils, and there is this little cluster of organisms here. And the question is this real or is it a contaminant? The gram stain actually showed positive staining, and it was a little bit challenging because there was also background inflammation. However, this is one of the best clues. If you see these organisms that are actually growing on the slide away from the tissue section, and over here, it appears that they are sort of in a slightly different plane. So this tells me that this is a contaminant. There's actually fungal growth on the slide itself, and it is not from the tissue section. And this is one of the ways, one of the clues that can help you to determine this. Here is another example of the fungal organisms growing on the slide away from the tissue section. Now, I'm just going to talk a little bit about frozen sections. This is a frozen section of a thyroid nodule, and very often in frozen sections we see these artifacts in the nuclei. So are they inclusions or not? It can be quite difficult and challenging to tell, but in this instance we're quite lucky. There's actually a proper true inclusion here where you can see that the inclusion contains this pink cytoplasm. Now here is an example of an intraoperative smear, and this is an H&E stain. And I often do this for frozen sections of the thyroid gland because you can see the true nuclear features much more readily and more accurately compared to a frozen section where you can have a lot of artifacts that can give rise to pseudo-inclusions. So true inclusion here. And I think H&E stain is fine. You don't have to have a PEP stain. Now, this is a gastric biopsy that was actually sent for frozen section, and you can see that there's Phoenician blind artifact here, and over here there is literally a hole. So this would be a very incomplete section. And on further sections with complete sections, and you can see the hole has filled up. Very frighteningly, the malignant cells were actually sitting in that area. So if we had not taken the trouble to do the sections into a complete section, then we may have missed the carcinoma on frozen section. Here is another artifact, which is folding of the section on frozen sections, and this usually occurs when the chuck is not cold enough. But I just want to show you that very, very nice, beautiful frozen sections are possible if cut well and stained well, and they can almost look like paraffin sections. So here is another artifact on frozen section, especially if an auto stainer is used and on the vertical plane when the staining solution, in this instance hematoxylin, does not actually reach the top of the specimen, you're going to get this very, very blurred out area that's very difficult to assess. So this is the reason for this artifact, and the solutions then need to be topped up. So I'm just going to say a few words about artifacts in cytology as well. This, of course, is one of the most obvious artifacts that we encounter quite frequently. This is air drying artifact in a Papa Nicolau stained smear or an alcohol fixed smear, and this is why it's very important for the smears to be immediately put into alcohol without even a 1-second delay. Otherwise, a specimen that would have had a lot of cells would then be rendered non-diagnostic because we simply cannot make out the nuclear detail. Here is an artifact in a urine sample, and this is some lubricant that has been used in catheterized urine. Here is an artifact in a PEP smear, and you can just about make out these polygonal structures in between the squamous cells, and of course you probably would be able to recognize this, especially if you polarize them. You can see the beautiful Maltese cross. And of course, this is starch contamination, something that all trainees should recognize readily. And they can be seen on light microscopy as well as these little polygonal structures. This on cytology, on the air-dried preparations, is ultrasound gel. It usually looks quite coarse and granular and purplish in color. Another example of ultrasound gel, and we don't see this on PEP stain smears, but just the air-dried Romanowski smears. A look-alike to the ultrasound gel would be these granular appearing platelets, and they are usually not as purple or coarse or large as the bits of ultrasound gel. Now this is stain residue, so this means that the staining solution has a lot of sediment, and it's stained sediment, and you can also recognize it because it goes beyond the smear onto the rest of the slide. So you need to filter the staining solutions. And this is also an artifact that comes out of epics processing. When you process fluids to reduce the amount of blood, sometimes the accompanying leukocytes from the blood, neutrophils, this is not reflective of acute inflammation. It was in the blood. It's just that they get concentrated because the red blood cells are removed. So something to be aware of. This is why we often do direct smears without epics, and then after that we do the cytospin preparations with epics. And if there's a lot of blood without much inflammation in the direct smears, we will not report them as acute inflammation. And here is an example of an ileostomy urine sample where you can see this vegetable-like cells. This picture is taken from Cytoweb, which is our online cyto resource. You can have a look at the entire page with the proper explanation there. And this is actually vegetable-like or plant-like structures. They're probably from the adhesive or skin barrier of urostomy care products. So you tend to see them in ileostomy urine specimens. And you can also sometimes see this kind of striated material that looks a bit like mucin. You can see this in urine, and you can see this sometimes in peritoneal fluid. And this is actually lubricant. So don't mistake this for mucin. It should be negative for DPES. So to end off with, a quick test for you to see how observant you have been. This is not just about what I have taught you from here, but also in daily life, what you see in the lab. So anyone knows what artifact this is? This is just a tissue section showing a lot of inflammation, and then we have a couple of squames here. Well, this is the famous sneeze artifact, where a person processing the tissue, the material, the slides, sneezes on a specimen, and then you get the squames coming out. This you probably can recognize as bony tissue, but everything is pink. You kind of lost the nuclear detail, and this is due to over decalcification. This tissue section looks extremely thick, and you can see that it's mostly adipose tissue. And if you see this appearance and you ask for another section that's thinner and you still get the same appearance, this will tell you that the sections did not process well. And the reason why they didn't process well, when I say process well, I mean in the machine, the steps of processing did not occur well, and this was because the original tissue sections were too thick. So if you see this appearance, please remember to cut your tissue sections not too thick when you are trimming, especially fatty tissue sections. And this one I showed you earlier, can you remember what this is? These purple spots. This is due, again, to insufficient dewaxing. And again, one more time, this material here, you should be able to recognize as gel foam. So in conclusion, artifacts may result in less than full use of the diagnostic information available. It may hamper the diagnosis or evaluation. It can occasionally be useful, such as cautery artifact. It can occur at different levels of handling, so a good understanding of the different steps is very important. And they can sometimes, in fact, often be prevented with careful handling. And awareness and prevention are of the utmost importance to avoid errors in reporting. And again, I just want to reiterate, certain artifacts, for example, specimen to specimen contamination, can give rise to potentially very serious medical errors and also potentially medical legal incidents. So I would encourage you all to be very observant and be very curious about how specimens are processed and understand every step of processing along the way as you trim specimens, as you handle cases, and also troubleshoot. Thank you.